evening.
Good evening.
Good evening. Good evening. My name is Gail Flannelly. My sister's in Central Jersey Club. I'm sure we all know each other. I'd like to extend a welcome to those who may be visiting us tonight. We are going to enjoy a lively conversation tonight with Dr. Seth Cohen. He's one of our local oncologists. He practices out of Monmouth Medical Center, highly respected and full of knowledge, and he's here to share it with us tonight regarding triple negative breast cancer.
Okay. So I want to thank the Central Jersey Club for inviting me this evening. I hope we have a small crowd, but I hope we have a loud and interactive crowd. And I do want to encourage people to ask questions. I'm going to present the topic at first, which is triple negative breast cancer, and go through some details. And then I want to encourage everyone to participate in a lively conversation, and we'll see where it leads us. The goal here is to educate the community about triple negative breast cancer, bring awareness about triple negative breast cancer, and have an open discussion to sort of empower ourselves with the knowledge rather than the fear of this cancer. So let's begin this evening with what triple negative breast cancer is. We call it triple negative breast cancer in specific because there are three markers that are negative, what we call the estrogen receptor, the progesterone receptor, and the HER2/neu receptor. Those three receptors being negative tell us that it's called triple negative, meaning those three receptors are negative. When we say they're negative, that means the estrogen receptor is less than 1%, the progesterone receptor is less than 1%, and HER2/neu is less than 1%. And those are three important proteins that we have in terms of our clarification and differentiating between breast cancer. For instance, we have what's called estrogen receptor positive breast cancer, which is another type of breast cancer. Those are patients that will invariably may or may not get chemotherapy, but will almost certainly get an agent that is targeted against the estrogen receptor, like tamoxifen, Femara or letrozole, aromasin or exemestane, or anastrozole or arimidex. This is in contradistinction to triple negative breast cancer, which does not have any targeted therapies that we can give, which makes it a much more difficult disease to treat, both for the doctor and the risk of recurrence, and for the patient, because these are patients that ultimately will require chemotherapy and not targeted therapy. And when we say the word chemotherapy, we mean systemic therapy that actually unfortunately has other side effects to the patients, like hair loss, things called neuropathy or numbness and tingling in the fingertips. So triple negative breast cancer, once again, is when your tumor is estrogen, progesterone, and HER2/neu negative, hence triple negative breast cancer that doesn't have the markers that we could treat with other targeted drugs like the estrogen receptor, as I just said, what's in the class of drugs called SERM, or selective estrogen receptor modulators. These are the tamoxifen pills, the letrozole or Femara kind of pills. Nor are these medications what we call HER2/neu positive. They're HER2/neu negative. And HER2/neu is a protein also expressed by breast cancer that has targets of a drug like Herceptin or Perjeta. These are drugs that have different targets for patients with breast cancer. So invariably, patients who have triple negative breast cancer are patients who have and require chemotherapy. They are predominantly and more often seen in the African American population in triple negative breast cancer. Why that is, we do not know. They are also seen in patients who are younger, meaning our younger patients. I have a triple negative breast cancer patient who's as young as early 20s. And they are typically more aggressive in breast cancer. There are other markers that make them more aggressive, but the fact that they don't have targets to actually hit well, and I say in the future we will have these targets, right now we don't have these targets, but the fact that they don't have these targets, A, requires that they need chemotherapy, and B, will also mean that they will have other systemic side effects from the therapy. So let's go into a little of what triple negative breast cancer means. About 20% of patients who have triple negative breast cancer will have a what's called a BRC or a BRCA mutation. And this is very important because patients who are young, who have triple negative breast cancer should be having genetic testing to make sure they do not have the BRCA or the gene, let's call it the breast cancer gene, that pertains to patients who have breast cancer and perhaps ovarian cancer, and to pass it on to their children. So it is important to know that if you have a triple negative breast cancer, these are patients that should have genetic testing because about 1 in 5 of them will have the BRCA gene or carry the BRCA gene. These are also patients who typically will present, as opposed to when they go for their mammogram, they will actually feel their cancer before they actually see the doctor, meaning they will know they have a cancer, as opposed to patients who have their yearly routine mammogram who will be told, oh, there's a spot on your mammogram. A lot of patients with triple negative breast cancer will literally be in the shower or getting dressed and have a lump on their breast, and will notice this even before they are mammographically detectable. That is because triple negative breast cancer are unfortunately more aggressive in their phenotype. They act more aggressive, they grow potentially quicker. So therefore, patients will feel them rather than before they are seen radiographically. So there are a few forms and ways of treatment. First of all, when someone presents with a breast mass, they will initially get a breast biopsy. That's a needle that goes into the breast. And the reason why that's important to be done is to identify what type of breast cancer they have. As I started off saying, there's triple negative breast cancer, there's estrogen positive breast cancer, there's HER2 positive breast cancer. So you could be in my waiting room in my office. There could be 100 people there, and I can tell you that a good number of them will not have exactly the same thing, even if they all have breast cancer, meaning they all will have different treatment algorithms that require them to go through because their markers or lack of markers that require. So triple negative breast cancer pertains to more aggressive cancers that are, once again, found by the patient before a mammogram could be done at times. They are typically found they are noted to be in a younger patient population, and they are prevalent in the African American population. So we're going to talk. I'm going to stop here for 2 seconds. We can unmute people, and if they have some questions, I will stop here before we talk about the actual treatment. So in terms of diagnosis, the diagnosis is made through a needle biopsy, usually a core needle biopsy, that will tell a person if they have triple negative breast cancer, that is estrogen, progesterone, and HER2 negative breast cancer. So let us take a little pause for see if anyone has any questions before we move on.
Dr. Cohen? Am I muted here?
Yes,
Can you hear me, Dr. Cohen?
I can.
Yes. Would you speak to how does family history play in triple negative?
So family history always plays into the genetics of disease. Obviously, if you have a person in their relatives, if you go through their family history and they said, you know, my aunt when she was 30 had breast cancer, and my especially male breast cancer, that raises the red flag of patients who are BRCA carriers. And those patients need to be obviously genetically tested. So my practice is anyone triple negative that's young always needs genetic testing. There's no question about it. Anyone could really do genetic testing. And the reason why we're going to get to why genetic testing is important in patients with breast cancer, because there are drugs, what we call PARP inhibitors, which are oral medications. There's a drug called Lynparza. There's a drug called Zejula, which actually is approved for patients who have, unfortunately, we'll get into it a little later on, with metastatic breast cancer. And those are options for cancer. So not only is it important to know from the genetics of the point of view of your family genetics, it's important for treatment and therapeutic options, whether you are a carrier of the gene. So family history is very important because family history pertains to a genetic component of the cancer. And that also influences the type of surgery one would have. For instance, if there's a strong family history of breast cancer in the family, and a young lady comes and says, you know, I have this new breast cancer that's triple negative. Sometimes in the surgical algorithm will be, instead of doing a lumpectomy, and if she has the gene called the BRCA gene, she may opt at that point for what's called bilateral mastectomies, meaning removing both of the breasts rather than just a simple lumpectomy. So family history plays into the role of the genetics of the disease, which is very important to know in terms of all our treatment algorithms, not just for the patient, but for their family and their children as well.
I have a question, Dr. Cohen, if I may. I have triple negative cancer. I don't fall into the category. I'm 66.
You look younger.
Oh, thank you. I've had the genetic testing and I'm negative for the BRCA gene. My question and my concern is I have a 40-year-old daughter. How much of a risk does she have? I have no breast cancer in my family whatsoever.
So there are clearly cases of de novo breast cancer, meaning there's no genetics that we know of right now. And I will tell you, just as an aside, I don't know how long ago, and you don't need to tell me these details, but I've had patients who 10 years ago were tested for, the gene. At that time, they were negative, and now there's additional testing called panel testing. So I actually have retested a lot of my cases of breast cancer, and some actually have turned out to be positive now for a different gene. There are different genes that we're always discovering. So at some point in your history, and I'm certainly not encouraging you to do that today, nor do I know when you were tested last, but I actually retest the genetics again because the genetic panel is an expanding thing. Medicine is changing here. And in medicine changing, the genetics of your disease, while we may not know them now, we will know them a little better in a few years from now, or we might have more information a few years from now. So that is one thing. Number two is if you are truly negative, and we right now will say that that is the case for you in particular, your daughter is not really at risk from the genetic standpoint of getting breast cancer. She clearly, just by being female, has a 1 in 8 chance of having breast cancer just by the fact that she's female. So even though she might not have the genetic component, she still has a risk factor and she still needs to be screened. Depending on the density of her breast on her initial mammogram, and if she's 40, probably she does need an initial mammogram, depending on the density of breast, and she may fall into a higher risk category that needs more monitoring based on the density of her breast and her mammographic findings at that time. So just because just because you don't have the gene and she might not have the gene doesn't mean you still don't follow her up, and depending on what her mammographic findings are, may need to have an ultrasound, an MRI, and various other things down the road.
Okay, thank you.
I have a question. How do you decide who gets a lumpectomy and who gets a mastectomy?
Okay, great question. So the surgical options, first of all, I'm not a surgeon, but I certainly do counsel my patients, and it's a joint effort here. Depending on the size of the tumor and also what therapy the patient gets will determine whether they're eligible for a lumpectomy or a mastectomy. So for instance, if on mammographic and MRI findings, we see that this tumor is, call it less than 1 centimeter. So that's like this big, pretty tiny. The option is really the patient's option at that point of what they want. A lumpectomy would be certainly a possibility, and a lumpectomy would be a lumpectomy with what we call a sentinel lymph node dissection or biopsy, meaning taking those first few lymph nodes from the technetium blue, and then that would be followed by radiation. If the tumor is larger, and we haven't gotten into the chemotherapy aspect of it, because this does play a huge role in the size and the treatment. If the tumor is larger, perhaps a patient might say, well, I want a lumpectomy. But size isn't the only thing, because it depends on the response to the treatment that you give the patient and depending on when you give the treatment. So that will bring up the next topic of how we treat our patients, what we call, and we're going to define into 3 different categories. One, we're going to call neoadjuvant. Neoadjuvant is a fancy term to say I'm going to give chemotherapy before surgery. And the reason why we do that pertains to your question. The second way we treat patients is adjuvant, meaning chemotherapy after surgery. And then the third way, and we don't like this scenario, is giving chemotherapy in the metastatic setting. So we're going to define those terms in a few minutes, but surgeries will depend on A, the size, B, the location, and the surgical, ability. It also depends on the genetics of the disease, as we just discussed a second ago. So if 1 in 5 patients with BRCA or BRCA carriers, 1 in 5 triple negative breast cancers are BRCA carriers, then the genetics of the disease will influence what kind of surgery you have. For instance, if you are a BRCA carrier, we would probably encourage bilateral mastectomies, which is a very difficult surgery, but one that will protect the patient down the road, as opposed to a lumpectomy. So the genetics plays a role, the size plays a role, the response to the chemotherapy also plays a role in the long term. So there are a lot of factors that play a role, all of which should be on the table and all discussed with the medical oncologist and the surgical oncologist. Okay, so now we're going to move on to those topics of the chemotherapy and the type of chemotherapy. And as I said, triple negative breast cancers don't have these targets, so therefore they are going to require chemotherapy. And any triple negative breast cancer, and every oncologist has different definitions of how large that needs to be that requires chemotherapy. But if radiographically, for instance, they're more than 1 centimeter and sometimes more than 0.5 centimeters, they will require chemotherapy. And there are various algorithms one can use. Sometimes doctors, as I said, give chemotherapy before surgery, what we call neoadjuvant chemotherapy, and sometimes they give it after surgery. So let's go over the benefits of giving chemotherapy before surgery. Certainly, if there's a large breast tumor, let's call it 4 centimeters, and the patient says, well, I want bilateral mastectomies, I will say that's great, but there are a few reasons to give chemotherapy in the beginning rather than after the surgery. First of all, it's a timing issue. It's sometimes hard for a patient to get into a plastic surgeon if they require plastic surgery, as well as see a surgeon and coordinate that care. While we're waiting for that, we could have already started and given some cycles of chemotherapy to shrink things down. That's issue number one, is a timing issue in terms of the response of therapy up front. Issue number two with therapy pertains to if someone gives chemotherapy up front and they have a complete response, their prognosis is much better. Number two, we also see what's called an in vivo effect, meaning the cancer now has disappeared or not disappeared from the chemotherapy based on the surgery after the chemotherapy. And therefore, we can determine whether the patient needs additional chemotherapy if there's any residual disease. So I can tell you that at our tumor board this morning, we had a case of a patient who had a triple negative breast cancer that was 3 centimeters. They had chemotherapy, and there are various types of chemotherapy. We can go through that as well. And after the chemotherapy, they had a very good response. That was the MRI finding. The good response was still residual disease. So the patient now will go for surgery. And after surgery, believe it or not, if there's residual disease, they probably will get additional chemotherapy even after their surgery, depending on the size of the disease. I know at my center, we have a study with what's called the immunotherapies to give for residual disease that's more than 1 centimeter. There's actually a Japanese study that was published in our journal called New England Journal of Medicine that showed giving oral Xeloda for triple negative breast cancer has about a 5 to 7% survival benefit in addition to their initial chemotherapy. So now we're adding benefit to more benefit and more benefit of chemotherapy. And the goal here is to really improve survival by giving various forms and different types of chemotherapy if the person is resistant to the initial chemotherapy that it's given. So we have neoadjuvant chemotherapy, meaning giving chemotherapy before surgery. If a person or a patient says, you know what, doctor, I just want to go for surgery up front. Sometimes they go for surgery and then post-operatively they'll have chemotherapy. So those are the two categories, what we call neoadjuvant chemotherapy. The medications we use are something called adriamycin, which is an anthracycline drug. which can affect the heart. There's a drug called Cytoxin. I'm just throwing out these terms, not that I'm going to quiz anyone, whoever's online and wants to have the quiz. It's 80% or above in order to get credit for tonight's program. That was a joke. Sorry. But there are various types of chemotherapy. The most common types for triple negative breast cancer is a regimen we call dose dense, which means AC followed by Taxol given in every 2 weeks fashion or a weekly Taxol fashion. That's the typical chemotherapy we use. Some people use a regimen called carboplatin and paclitaxel. In fact, if you knew or know that a patient has a BRCA carrier, is a genetic carrier, the platinum drugs called carboplatin actually has a very excellent efficacy in actually causing a complete remission. So I've actually used for my younger patients who need aggressive therapy a regimen called AC followed by Taxol and carboplatin, because I feel like you got to throw the sink at them because the goal here is survival. The goal here is not just to shrink something down. The goal thing is to shrink it down and it never come back. And then if there's any residual disease, even add on a drug called Xeloda postoperatively or a drug called Keytruda for immunotherapy. So those are the names of the drugs. We're going to move on now. I want to stop here. The good news I will tell you before we take a little break for any other questions and then finish up with metastatic disease is that if you are 3 years out from your diagnosis and your therapy, the risk of recurrence at 3 years for triple negative goes down dramatically. That doesn't mean it goes down to zero. I wish to say it would, but it goes down dramatically. That is in contradistinction to patients who have estrogen receptor positive disease. I have patients who are 17 years out who unfortunately have had recurrences 17 years later now. If you're triple negative, the chance of recurrence as you move out further goes down significantly. So it's a big, take a deep breath for the first year, 2 years, and 3 years, and hopefully you can exhale as time goes on. So the risk of recurrence goes down significantly. So I'm going to pause here for any questions before we talk about metastatic disease.
Dr. Cohen, I have a question. A patient with triple negative that got a lumpectomy did not have chemotherapy. What are the chances of reoccurrence?
So that depends on a lot of factors. Number one, the actual size of the disease. Meaning, so if it was 0.3 centimeters or 3 millimeters, not so great. And the chances of coming back are there. I would call it about 8 to 10%. If it was a 4 centimeter mass, the chances of coming back are significantly higher. And there are other factors that we didn't talk about, lymph node factors, meaning are there lymph nodes involved or not?
No lymph nodes are involved. No lymph nodes are involved.
There's a score called a Ki-67 score, which is a tumor proliferation rate. If that Ki-67 is low or high, typically with triple negative breast cancer, that number is above 20 to 25%. So if it's a high Ki-67 score and a large tumor, the numbers go up significantly, 30, 40%, 50%, depending on the size of the tumor, other characteristics of the tumor called lymphovascular invasion. So there are other characteristics, not just the size of the tumor, but also typically triple negatives have what's called grade 2 or 3, as opposed to estrogen receptor positive patients who can have a grade 1 tumor. So there are a lot of factors involved. And unfortunately, the best therapy for these patients is chemotherapy. If they didn't have chemotherapy for their own personal reasons, that's, the oncologist had to make it clear to them the benefits of chemotherapy versus the risk of not going chemotherapy. Doesn't mean everyone has to do chemotherapy. That means it needs to be discussed. And ultimately, it's the patient's decision of whether they want to do chemotherapy or not. But the risk is certainly substantially higher. And chemotherapy has a profound reduction, much more than in estrogen receptor positive cancer. So you can see I'm paralleling two different cancers here. You have triple negative and ER positive breast cancers. So everyone thinks, well, I have breast cancer, I'm doing great or not great. I went to this place or that place. It depends not so much on the place, it depends on the disease that puts the risk of recurrence. So if you're an ER positive breast cancer, believe it or not, the benefits of chemotherapy are substantially less. We're talking in the range of maybe 5-10%. The benefits of chemotherapy for a person with triple negative breast cancer could be well into the range of 30-40% because they don't have that target to give other therapies to. So there are a lot of risks and factors here that have to be involved, and also comorbidities. Does the person have diabetes? The person have heart disease? What side is the tumor on, left or right, will determine radiation risks and factors, whether cardiac long-term risks. So there are a lot of factors involved, but typically triple negative breast cancers have a substantially higher risk of recurrence than estrogen receptor positive breast cancers because they don't have that, they can't be afforded that pill, tamoxifen or Arimidex or Aromasin, whatever pill that is, down the line that patients take for 5 years. So they need the protection up front to get them over that hump for the next 3 years.
Thank you.
You're welcome. Okay, so now we're going to talk briefly about metastatic breast cancer. And I'm going to talk about two different things because in the last couple of years, there have been some exciting breakthroughs given the fact that it's really quite disheartening when you see a patient who has recurrence of breast cancer. I could tell as much as the patient is crying, the doctor is also crying inside because this is really terrible. And we at least now have a little more research and hope on this. And in the past, I think 3 years ago, we had very few drugs available for patients specifically for triple negative breast cancer in the metastatic setting. And now we have 2 drugs that are FDA approved. And these are pretty substantial in their benefits. Unfortunately, when patients have their breast cancer spread, we're not really talking about survival. We're talking about management and maintaining their cancer where it is. The first regimen that we use, typically if they're what's called PD-L1 positive, is an immunotherapy called Tecentriq, very similar to another drug called Keytruda or Opdivo. If you watch any TV, I think you see this more than I do. There are various types of drugs that are on the market, which are immunotherapies combined with a chemotherapy that have really improved survival by a substantial amount if they're PD-L1 positive. So PD-L1 positive is not done by us patients, it's done by our pathologist, and we do a special stain, which gives a score called a TPX score. That score is, if it's greater than 1, patients are eligible for the immunotherapy plus the chemotherapy in a drug called Abraxane, which is similar to a drug called Taxol. That's breakthrough number 1. So that has actually increased survival by a substantial amount. I'm not talking about days, weeks, I'm talking about months survival. I think it's up to 10 months survival benefit versus the standard of care. I actually have been fortunate to also use this drug called Trodelvy. It was FDA approved now probably a year ago. And I have a couple of patients with triple negative breast cancer that are just hitting home runs. And it is one of the most exciting things to do is to see one of my young patients. I don't even know if she's on or not. I hope she's not. But if she is, she shouldn't say anything right now. She has metastatic breast cancer. She actually had blurry vision, had brain mets. We resected the brain, did what's called gamma knife to the brain, and now she's on a drug called Trodelvy. And I can tell you that her disease is melting away. It is a sight to be seen. The drug called Trodelvy is a drug. It's called a TROP2 inhibitor. This is a novel drug. We didn't think in the clinical trials, it didn't look as promising. And to be honest, now I use it. I have a couple of patients on it that are doing out of this park, amazing. And these are patients with brain metastases now. I have someone, I think 2 or 3 years out easily, which is quite exciting for this. So I have a saying that I always tell my patients, the longer you live, the longer you live. And it sounds like an odd saying, but the longer you live, the more research is going to be done on your breast cancer. And in specific, triple negative breast cancer is going to have breakthroughs down the line. The goal as an oncologist like myself is to keep you alive with a quality of life longer. And the longer we could do that, more therapies will come down the line. So I'm going to stop here, and I want to thank everyone for listening in and answer any other questions they might have.
Dr. Cohen,
Yes.
it's Christine. I don't have my video on, but I just saw you today.
Okay.
You know who I am, right?
I won't say anything.
Okay. Anyway, you said earlier about the 3 years, right? When you get up to 3 years, your breast cancer risk, subsides, correct?
Well, I said the risk of recurrence after 3 years is reduced substantially. That doesn't mean it's 100%. No one should ever use that words, but to be
Okay.
careful here with our words here
Right.
is that once you hit that 3-year mark, the risk of this coming back decreases substantially. It's year 1, 2, and 3 that there's a higher risk of this cancer coming back.
Okay, and my other question is that if your risk goes down after 3 years substantially, why say, 5 years out, 6 years out, 10 years out, do people have a reoccurrence?
So they sometimes could have a reoccurrence, but just because you had breast cancer doesn't put you at risk for other breast cancers. I've had patients who have triple negative breast cancer, 3 years out, 4 years out, and then the reason why we follow up because is that they can have a different kind of breast cancer in another breast or somewhere else. So we follow because you can have an estrogen receptor positive breast cancer somewhere else. As long as you still have breast tissue, you have a risk of having breast cancer. That's just the risk factor.
Okay, and that's, what I mean, like your chances go down substantially, but is that just targeted towards the breast, or that's everywhere in the body?
That is that specific breast cancer that the risk is reduced. I'm not talking about any other cancers. I'm just talking about that cancer that you were diagnosed 3 years ago. At that point, after 3 years, that risk of that coming back is reduced significantly for that breast cancer in specific for returning.
Okay.
Can I ask one more question, please?
Sure.
So many times I have heard people say, I'm cancer free. I've had surgery, chemo, radiation. I'm having another mastectomy next month. The doctors have told me there's no way that they can tell me that the cancer is all gone from my body. How do you know when you reach the point where you're cancer free, when you've beat it?
Yeah. So, to make the distinction between triple negative, I'm not going to speak about all cancers because I think everyone loves to use the term "I'm cancer free," and
Right.
they want to say that like the day they leave the surgical suite being rolled out. It's actually what we all want to believe, although the reality of it is that is not necessarily the truth. Estrogen receptor positive breast cancers, I don't tell patients they're cancer free. I say doesn't look like there's any recurrence at this time. With triple negative breast cancers, since they're somewhat, I would tell you, more aggressive, and when you reach that certain hump after years, as years go by, the risk of that cancer does go down significantly. It's the analogous I would call you for what's called an aggressive lymphoma, what's called a diffuse large B cell lymphoma, very aggressive, high Ki-67. Those patients are either going to be cured very quickly or not cured at all. And in some respect, that is similar or analogous, not to the exact measurement, but to some extent to triple negative breast cancer. If they reach over that certain hump over a certain time, the risk of that specific breast cancer returning diminishes significantly, and they probably will be cancer free. But there's no guarantee of anything. When the phrase of cancer free, I find is to be, my doctor said I'm cancer free. I'm like, that's great that your doctor said that, but I don't know if he knows your case at all.
Right. Okay, thank you.
Dr. Cohen, I have a
Yes.
couple of questions if you don't mind.
Sure.
I was diagnosed with bilateral breast cancer in 2014. I had bilateral lumpectomies in both in 2015. I had the radiation, and I'm presently doing Xgeva injection because it metastasized and it has been confined. They're telling me because I have to go monthly for injections for chemo with the flaxidant. But I'm also taking a pill called Ibrance. So far everything has been okay, but they're talking about removing me from the Xgeva because of the side effects.
Yeah, so I'll just stop you right there. First of all, if you're on Ibrance, I presume you have an estrogen receptor positive breast cancer, not
Correct.
estrogen receptor
Correct.
negative. So
Correct.
just not to confuse the audience here, because we were talking today about triple negative, which is estrogen receptor negative breast cancer. But
Okay.
I'm still happy to answer your question. I just want to make sure we're all on the same page in the audience.
Okay.
That it's not the same breast cancer what you have versus what we were talking about tonight.
Okay,
You
which
have,
is
if you're on
great.
Ibrance, you're estrogen receptor positive breast cancer.
Okay.
That's number one. Number two is I do not give Xgeva for 5 years on a monthly basis because there are major risks, what's called osteonecrosis of the jaw or ONJ.
Correct.
I don't even give Xgeva, by the way, for patients more than every 2 months because I've dealt with ONJ since these products have come out. So one has to be very careful with them.
Well,
And
that's, yeah.
I think
Some
not to
choices.
criticize, God forbid, any of your doctors, because I don't know your case well enough, but I don't continue monthly Xgeva indefinitely because usually we go to an every 3 month schedule after we hear 1 or 2. Whatever your doctor did is what they did, but I don't give Xgeva that often for the risk of osteonecrosis.
And, okay.
So you have an estrogen receptor positive breast cancer, I guess. Is that correct?
That's correct.
So it's a little different from the breast cancer that we're talking to tonight. You probably are also on some other medication with the Ibrance, not just Ibrance alone, in addition to the Xgeva, maybe Faslodex, maybe.
Correct.
Yeah,
Correct.
right. So that's a monthly shot. Faslodex is for metastatic breast cancer. And if it's confined to the bones, everyone could, thank God, live a long and happy and healthy life, even if it's confined to the bones. I have patients in my practice who are 10, 15 years out with bony only disease.
Okay.
But that's different and contradistinction once again to ER negative breast cancer. Because if you didn't have the Faslodex and Ibrance, your algorithm would be a lot different in your treatment.
Okay. Thank you.
You're welcome.
I have a question. Does age play a factor? So I was 33 years old when I was diagnosed with triple negative breast cancer. I don't have any mutations that I know of. That put me at a higher risk for recurrence or maybe a new cancer developing.
So age plays a lot of roles. Typically triple negative is in the African American population and the younger population. We probably, to be frank with you, don't know enough about it, and there has to be some component that is causing this, and we just don't know that at this point. So age has to play a role in this. People who are older also get triple negative breast cancer. So why does that happen? So there's no real defining one thing here. There probably is a genetic component to it or some protein that's turned on. These medications that I just mentioned tonight, Tecentriq if you're PD-L1 positive, Trodelvy if you have metastatic disease for a TROP2 inhibitor, those medications are the start of this interesting journey in triple negative breast cancer that we're going to take. And the truth is, I don't think that's the end of it. There are clinical trials here and there. There's, vaccine trials here and there. They're all over the place. My patients, I have one patient who's so sweet. She brings in all the clinical trials every visit to me. And I love it because it's like I get to see what's going on in her mind, even though she's doing, thank God, well, but we get to see what's going on in terms of the clinical trial arena. There are a lot of trials out there. One has to be careful with what trials there are. But once again, age always plays a role. Age also plays a role in your ability to tolerate things and your other comorbidities that you may have. So age is important. But once again, it's still similar in terms of whether you're old or young. Triple negative breast cancer doesn't have a great marker or target at this time.
What is your experience with Keytruda? Because I know that just got voted on, but that's only for metastatic disease. They're not really doing it in early stage.
Correct.
Where do you see that?
So I have a clinical trial right now with Keytruda in patients who have triple negative breast cancer in the neoadjuvant setting, who have residual disease. We give them Keytruda post-operatively if their tumor is still there. But those are patients, and if I've used PD-L1s or immunotherapies for a while, those are patients who have what's called TPS scores of greater than 1%. So if their if they're negative for this TPS score, there is unlikely going to be a great benefit to immunotherapy. Keytruda is approved only in the metastatic setting. It's similar to a drug called Tecentriq, and the data is promising, but it's not the final answer. It works a little differently. I know we use PD-L1 therapies or immunotherapies in melanoma, Hodgkin's disease, non-Hodgkin's disease, renal cell carcinoma, bladder cancers, lung cancers, breast cancers, skin cancers. I mean, if you go to the website of Keytruda, it's like pick your cancer. There's like 20 FDA approved regimens that you have with it.
Dr.
Thank-
I have one quick question in regards to a triple negative breast cancer. For a younger person who is aware that, this is in their family, that their aunt or their mother had it or whatever, is there anything that they should be aware of that they can do to decrease their chances of possibly having the cancer themselves as they age?
Yeah, so the first thing is genetic testing, meaning if they know there's a family member that has breast cancer, triple negative or whatnot, they should encourage the person who has the breast cancer, and that is what we call the proband, meaning that's the patient who has the breast cancer. They should get tested for the genetics of the cancer. And then, there are what we call high-risk breast cancer clinics that my center has, for patients who fit certain criteria based on their mammographic findings and their family history. There's some points we give it. There are different, I call it algorithms that say, well, you're at a higher risk because your family history, your mother, your aunt had breast cancer at a certain age. You had a mammogram that had a finding that required a biopsy. So there are different points that we assign. And if you can be put into a high risk clinic potentially, and those high risk clinics then will screen you with various methodologies, i.e. MRI, ultrasounds, or mammograms.
So they should have a discussion with their gynecologist.
I think they should actually go to a breast center that offers these services to them if they think they're at a higher risk, and they can be analyzed. I know at Wilentz Breast Center in Monmouth and through the Barnabas system, patients fill out forms and we actually assess each patient to see if they're high risk from the get-go. If they are high risk, then we actually put them in the high risk stratification and category for imaging and whatnot.
Thank you.
Okay. Well, I want to thank everyone for their time. This has been very nice. Next time I expect 200 people, not 20. But I want to thank the opportunity to be here tonight. And I think this is my first time doing this with this group and association. And I told everyone in the beginning that I think what I would like to do is this should be the start of a great partnership of educating the community. And I'm more than happy to continue this, not just me doing it, but for my colleagues to get up here and help educate the community. So I want to thank you for this opportunity, Kanisha,
Yes,
and
thank you, Dr.
all the
Allen.
organizers
Thank you.
of tonight's event.
Thank you
Dr.
very
Definitely
Thank
will not be the last time we bother you for information, put it like that.
Was it
Our
that
president
hard?
is also, no, you were a pleasure. You really were. Our president is online tonight, Elise Franklin Owens. Elise, do you have anything to say, party?
Thank you so much, Dr. Cohen. It's been so informative. Thank you for taking your time out to speak with us, and I hope that we can continue to partner with you. Thank you so much.
My pleasure. Have a great night, everyone.
Okay,
Thank
you
you.
too.
Thanks.
Good
Good night,
night.
everybody.
Thank you. Good night.
Bye.